frequency oscillatory ventilation, which is associated with actually a higher mortality as compared to other forms. So these are some rescue therapies that we might discuss, some other time. But to concentrate on PEEP titration, we all know positive and expiratory pressure is the alveolar pressure above the atmospheric pressure that exists at the end of expiration. And we have two types of PEEP, extrinsic and intrinsic. The extrinsic is the one which we apply to the patient in the mechanical ventilator, but the intrinsic PEEP is it's a PEEP that occurs due to incomplete expiration. This is seen in patients with COPD, patients with asthma, due to air trapping and dynamic hyperinflation. PEEP has, it's very useful. It improves hypoxemia, decreases shunting, decreases the work of breathing and VQ mismatch, and it prevents also atelectasis trauma. But when you have low PEEP, lower than what is needed, there is significant opening and closing of the alveoli, which causes atelectasis trauma, and it causes more injuries to the surrounding alveoli too. But at the same time, too much PEEP is not good. It might exacerbate hypoxemia. So we have to balance this question. In one paper, these are the pictures that I found. So they studied patient in A, they didn't apply any PEEP, and in B, they applied around 11 of PEEP. And you can see it that there is significant difference. There is no significant difference, especially on the left side in both pictures. But in C, when they applied some recruitment maneuver of 40 of PEEP for 40 seconds, definitely the normal side, the right upper normal side, is hyperinflated, but the left one is also inflated well. And when they go down from 40 to PEEP of 11, clearly there is significant improvement. Significant.
So they went to PEEP of 40?
Yeah. Yes. So there are papers in recruitment maneuver. We are not going there, but it's not really people. There are people who like it, but there are people who have so much reservation with the recruitment maneuver too. So the
study showed it's harmful.
Yes. So the initial PF ratio, if you see it when 0 PEEP and the PEEP on 11, it's 170. Subsequently, it has increased to 350s when they did the recruitment maneuver and keep it around 11. So the same tidal volume definitely will have different effects on airway pressures, for example, in A and let's say in D, because the whole tidal volume will go to that part of baby lung. But if it goes to this one, the D, it will be distributed in both lungs. So there are different negative effects of PEEP that we have to be aware. There are decreasing preload, barotrauma, a decrease in RV afterload, which is detrimental in patients with RV dysfunction and pulmonary hypertension. So when we do it in such patients, we have to be very careful. So PEEP titration can be done in these different ways. The first one is the PEEP FiO2 scale, and we'll try to discuss them in order. If you have any questions or any type of ideas, you can stop me and ask. Okay. This is the PEEP FiO2 scale. We use it, at the start of usually ARDS patients when they are intubated. We try to use this in our ICU. Usually we start with, it says 8, but we start with 6. We start with the calculation of the tidal volume, and then we go to the plateau pressure because that's our goal. The goal is to not go above 30 in the plateau pressure. There is a lower PEEP table and there is a higher PEEP table. But if you see it, even the lower PEEP table is not really low. So it's during the COVID times, for example, when we intubate patients, usually they need 100% of oxygen. And we don't usually go to like a PEEP of 18 or 19 or 20. We take our time and we try to use also other modalities. So it is very important, like at the start of, taking care of these patients after intubation. But we don't have to literally take it and go for the higher PEEP because I'm sure when we go very high with the PEEP, the plateau will be high and the tidal volume should go down, which creates its own problems. So widely used, we start with the tidal volume on the predicted body weight, and the plateau pressure goal is around 30, and it gives us a suggestion for PEEP depending on the FiO2. We have to see the response of the patient. We have to see the plateau pressure, the hemodynamics of the patient while we do this. So if you use, when patient reaches 100% oxygen, a PEEP of 22 or 24, that's very high. So we try to manage that with the tidal volume and with the plateau pressure. Even if it is simple to use, ARDS is a heterogeneous problem, and you can't really prescribe just a table to manage it. So there are different patients who respond differently, and we have to act accordingly on these patients. So it's a suggestion of PEEP for the FiO2 we are using, but we don't have to literally take what they have written in the table. That's what I think about it. But which table to use, the lower or the high PEEP table? There are different papers, a lot of papers written. There is a meta-analysis that I found in American Thoracic Society. The trend is it favors high PEEP for mortality, but the p-value is greater than 0.05. What it clearly shows is it shows better oxygenation when you use a higher PEEP table. So these are the studies. So this is for mortality. As you can see, the 95 confidence interval, the 95% confidence interval passes through one. So statistically, the mortality is not significant, but it clearly favors, a higher PEEP type of approach in patients with ARDS, even for mortality. This is for oxygenation. It clearly favors a high PEEP strategy. It's clear that oxygenation will be much better. But the problem is oxygenation does not improve mortality, and we have to be very cautious on using very high PEEP in these patients. We have to use low tidal volume and make sure that the plateau pressure is less than 30. And by all means, we have to avoid further lung injury in these patients, because the basis for ARDS management is avoiding further lung injury in these patients. The other is the tidal compliance or the driving pressure. Studies on lung protective strategies usually use tidal volume to a normalized tidal volume to the lung size, but in patients with the ARDS, we know that these patients have, functional baby lungs, very smaller lungs. And what these people, Amato et al. In New England Journal of Medicine, what they hypothesize is that if we normalize the tidal volume to the respiratory system compliance, rather than just taking it to tidal volume to the predicted body weight, it might be a better way of managing the PEEP in these patients. We know that driving pressure is a change in tidal volume, the tidal volume over the respiratory system compliance, and it can also be calculated from the plateau pressure with subtracting the PEEP from the plateau pressure. So in the Amato trial, this is a post hoc analysis. They didn't really go for the driving pressure in this study. So that is one weakness of the study, but it's a good study. So they use different studies. They just took a sample from the different studies. So they don't have any patients by themselves in this paper. So what they did is they took patients who have similar PEEP in the first graph, and they tried to study the mortality in these patients because they matched everything. The PEEP is the same, but this gray one, it is the driving pressure in these patients. So the driving pressure increases. And what they saw is in these patients, when they match the PEEP, the mortality increased. And then they took other patients who have similar driving pressure. And when they took those patients, the PEEP also increases, it goes up, but there is no significant difference in mortality in these patients when they keep the driving pressure the same. The third one, if you see it, what happens was they keep the plateau pressure the same on everybody, and they studied those patients, and the PEEP increased, the driving pressure decreased in these patients. And what they have observed is the mortality rate drops significantly. So what you can take from this is sometimes higher plateau pressure, we say it's bad, but it might not be as bad always. So it says that this paper, because this, if you see the middle one, the plateau pressure has increased on patients, but the mortality is not that different. And higher PEEP does not always give you, is not always protective. You see, the mortality is the same in these patients. So, but in here, mortality has improved. So, in here also another study, what they found is that when the driving pressure goes up, of patients, the probability of hospital days increases. There is a similar, somewhat similar relationship with the plateau pressure, but it is more significant with the driving pressure. So there is significant difference between the two graphs, if you see here, at around a value, a driving pressure value of 14. So that's why they say driving pressure should be kept below 14. So it looks, driving pressure following it looks good, but why not we target driving pressure? There are different, as I have told you, the studies that I showed you earlier. These are subgroup analysis, post hoc analysis. So they generate some ideas for further study, but they don't give you a good, solid clinical conclusion. So they can't say this, they can conclude from that. The other is higher driving pressure is clearly associated with increased mortality. But why is this? Why is this happening? Is this because the ARDS is very severe with fibrosis, and that's why they have higher driving pressure? That could be the explanation for these patients. And when we target low driving pressure, we have to use low tidal volume. We have to crank up the respiratory rate, but still patients have hypercapnia. So there are a lot of other effects that happen when we target low the driving pressure. So that also affects the general outcome on the patients. The other thing is the goal driving pressure also was not clearly studied. So this is people's suggestion. Okay, let's keep it below 15. That's it. No randomized control trials. I saw one pilot study which tried to check feasibility of targeting driving pressure. They said, yeah, we can target the driving pressure, but they didn't. They use very small number of patients also. So those are the problems associated with tidal compliance or driving pressure.
So now, do you want us to target low driving or use it as a goal? right? I mean, do we need to like manage ARDS with a goal of not exceeding 15?
What did you understand from what he said?
That's right.
Goal.
So what do you mean?
Yeah, but I mean,
So what would you take from this, what he said,
Mhm.
to your patient? What are you gonna do?
so I will still use beep to the point that not exceeding driving pressure of 15. I mean, I still use high beep, but I pay attention to driving pressure as well.
So what's driving pressure? What is driving? What's the equation of driving pressure?
The peak
So
plateau minus.
peak.
Yeah.
So if you go up in your peak
Mhm.
and the plateau stays, your driving will go up or down.
Yeah.
That's right. Is that right? So the plateau is the same and the peak is going up. So your driving pressure, it's like number wise, so not real patient. Number wise, it should go down. Is that right?
It depends on the patient.
Yeah, no, like numbers. Like
Numbers,
if you have
yes.
plateau pressure is 30 and PEEP of 5 and I went up to PEEP of
10.
20.
Mhm.
So now the difference is 10, is that right?
Mhm.
So now our driving pressure is less than 15.
Mhm.
And that showed there is trend toward improved mortality.
Mhm.
But as you mentioned, it depends on the patient. Sometimes if I go up to 20 of PEEP, the plateau will go up to 50.
Yes.
So did I have any changes in the driving pressure? No, so driving
No.
pressure has been the same.
Mhm.
Did you do any benefit for this patient? No. Is the patient high risk for biotrauma and volutrauma?
Yes.
Yes. So it depends on the patient. So if you can titrate up the PEEP and the volume without risking the patient to make the driving pressure less than 15,
Mhm.
that's amazing. If you cannot do it, then you will not just like look at, because it's obviously if you go up in the PEEP, like, okay, PEEP is 12, let's go up to 14. The plateau went up. Let's go up to 16. Plateau is going up. So you're not recruiting, you're just over distending
Mhm.
what you have.
Yes.
However, there's no one in this world knows like how long you should keep it.
Mhm.
Like, oh, let me go up 2 and leave it for 30 minutes and come back.
Mhm.
Oh, after 30 minutes, the driving pressure start going down. Or sorry, the plateau pressure start going down.
Mhm.
What does that mean? So you were 10,
Yeah.
you went up to 14, you went finishing the round, you came back to this patient, the plateau pressure instead of 35,
Mhm.
it went down to 30 with the PEEP of 15.
That means improved compliance.
So you recruited some alveoli, is that right? So
Yeah.
it means that it's still recruitable.
Mhm.
But you cannot choose one thing to do. It's like multiple things. But what
Yeah.
he's trying to say, there's no randomized trial saying, like, if Dr. Jasmine come to me and say, hey, you know what? I don't care about driving pressure. I will not do it. I will just go with the plateau and peak. I cannot prove he's wrong. And he
Yeah.
cannot prove I'm right or wrong. So there's no randomized control trial, but most of the expert opinion and the post hoc analysis and the retrospective trials showing that keeping driving pressure less than 15, there is trend toward improved mortality and oxygenation.
Question here, speaking of the equation, if I have the choice to choose increasing the peak versus lowering the tidal volume,
That's a good question.
which one do I go with?
Whatever you want to do. So for example, let's say you increase the PEEP and you're not recruiting more. How do you know you're recruit? Because the plateau maybe with time may go,
Yeah.
may come down, right? So you're recruiting more. But let's say, Dr. Maggie said there's a patient who very non-compliant lungs, you increase the PEEP by 2 and his plateau pressure will go up by 4, for example, right? So you're actually making something lower. The last patient, I will not increase the PEEP. You may be able to decrease the tidal volume. You will have the same effect, which you will have the lower driving pressure. Obviously, how low can you go? How low the patient can tolerate? That's debate. You can go as low as 4
Depends on the
per
gas.
kg and all that stuff. All that stuff that goes along with the patient. Will this save the question is, will this save the patient's life, or make them improve mortality? We don't know. I think what Yunus is saying is that driving pressure just tells you to me, the higher driving pressure, the sicker the lung is.
Yes.
And that's why the patient has a higher
Mortality,
mortality
yeah.
rate. But the answer is, well, if I fix the driving pressure, will that mean that I'm saving a patient life? I don't think we can comfortably say that, but I think you can try to.
If you're not harming the patient.
If you're not harming. So it's not one size fits all, but that from the research, it means the higher driving pressure, the sicker the lung, the higher risk of mortality.
Mhm.
Does fixing that help the patient? We don't know. That's the this.
Because if you think about it, if a PEEP of 5 make you a plateau of 40, what does that mean?
There's no
Your
compliance.
is gone. It's like a stone. It's like
Very severe, yeah.
so that's very stiff lung.
Mhm.
So your target is trying to recruit without giving harm. So it will take a long time. That's why ARDS patient is not like put division, mechanical ventilation, and go home. It's like recurrent evaluation.
And obviously they try to make it more standardized so that the whole world can manage and not everyone is like a critical care physician and stuff like that. But again, it's not really, it's not as homogeneous as they make it to be.
So the next concept that for PEEP titration that we are going to discuss will be stress index. We know that when we use, a higher ARDS net tables, it's going to induce alveolar hyperinflation. So they came up with the concept of stress index, which they are saying is more physiologic titration of the PEEP. Aimed to decrease ventilator-induced injuries to the lung. So basically, stress index measures how the pressure within the whole respiratory system changes as we take a deep breath, as the patient takes a deep breath, or we give an inspiratory pressure for the patient. And usually it is determined by on a brace basis, and we have to change the flow. It should be changed to a constant flow ventilation so that we avoid a variable of flow in relation to the pressure that develops in those patients. We usually use like a decelerating type of flow in our ICU. So when you try to check stress index, I think it's better to change it to a constant flow and try to check the stress index.
You have to, not you have
Yeah.
to.
We have to, yes. So this is, they did this paper on 15 patients. So as you can see, the flow is the same on all types. When the stress index is less than 1, the first one, if you see it, the pressure at first, it goes very high at first and then basically stabilizes. So they said this is a stress index is less than 1. But if you see the second one, the flow is the pressure development is constant with this one. So this is the stress index equals to 1. And in this one, in the third one, you can see that pressure, enlarges at first slowly, and then it goes up very significantly. It goes up very fast. So whenever we see this in patients, the last one, this one, we need to go down with, whatever is necessary with the PEEP to make it here, to make it at least a stress index of 1. So when they measure different things in these patients, in these 15 patients, the elastance of the lung, different inflammatory markers, interleukin-6, TGF, and other inflammatory markers significantly decreased with these patients. So it's very difficult to say stress index changes anything, to be honest with you. The size is very small, and it's not also, a randomized controlled trial. But at the same time, it's clearly the inflammatory markers have decreased, and the other markers of ARDS have improved in these patients. So we can take it as one way of decreasing or titrating the PEEP in patients. The other thing is the lower and upper inflection points. We all know that we discussed earlier that when PEEP is very low, definitely it significantly causes atelectative trauma, not only to that alveoli, but to the surrounding alveoli too. So we go up we add some PEEP, but we add this PEEP until we reach to the upper inflection point, where If we increase PEEP after the upper inflection point, what it means is there will be breakage of the alveoli, more hypoxia happens. So the plan is to keep the alveoli in the lung in this sweet spot between the upper and the lower inflection point. When we see, the volume pressure curves. How practical is it? Honestly, I haven't tried to go down or up with the PEEP with this method. I'm not sure the practicality of it. But the suggestion is keeping the PEEP in these two positions might be a good
And if
idea.
you go back a little bit,
Yeah.
so what else that will give you clue
How-
that
How do I know I am in this zone?
that's right? So without looking at the pressure, you can look at the pressure volume curve in the mechanical ventilation itself.
Mhm.
But what else that can give you a clue that's like your lung right now, it's in this point.
Plateau.
That's how they did the plateau and the peak pressure that you can look at, and you can know that the infection is like, and it's not in the higher inflection point.
Mhm.
However, but you can look at the curve itself and you see how the changes in the curve on your mechanical ventilation shifting to the right or to the left, or like there is the peak there, the bird beak appearance on the curve itself. Like you can see that the pressure is like. So there is like, if this is the pressure and this is the volume, if the pressure increase without increasing the volume, what will happen? It will go like
down.
this, all right?
Mhm.
So like this appearance in here, sometimes you can look at it in your mechanical ventilation and you can know that the volume is the same despite that you're increasing the pressure. So that's what, like in some patient that can lead to, like, not some patient, like that can lead to more injury comparing to just like titration. But you cannot just go with it only. You have to look at everything else.
Mhm.
I'm not sure if you, sorry, I'm not sure if that's about it, but they talk about using an oscillator, like a ventilator. The oscillator actually you can put it in the inflection point, just right there. You can actually pick and choose where you want in terms of the inflection point and just put it right in that sweet spot.
Yeah.
But studies came out, showed that the oscillator increases mortality. That's why you probably got that seen an oscillator ventilator and all of them. So that's the idea, but like I said, oscillator has tried to do that and it did not really help the patient.
So what PEEP should we start at? Like some patients I've seen, they are requiring very high PEEP to be recruited. And then we go down every few minutes, check if the PEEP plateau is going down by PEEP.
Well, we'll go over it at the end of this. Let him finish all the way of titration and then we can summarize it.
Yeah, so the other one is esophageal pressure. We know that airway pressure, it's a poor surrogate. There are a lot of players inside, the airway pressure, but the transpulmonary pressure, if we have it, it's the true distending pressure that we can, that will help us how much pressure is applied to the lung itself. And the transpulmonary pressure is the alveolar pressure minus the pleural pressure. And when we get the transpulmonary pressure, it allows us for differentiation of lung compliance from chest wall compliance. We know that the respiratory system is a mechanical system with different forces like resistive and elastic components. In the equation of motion, of respiration, there is pressure from the inspiratory muscles and there is pressure from the ventilator, which is equal to the resistive pressure, the elastance pressure, and also the PEEP. So these are the pressures which go in different direction, just like Newton's third law. So there is a lung, there is a chest wall, and the condition of the patient itself. Patients who have obesity, different pathologies, including pleural effusion, ascites, intra-abdominal pathologies, play a role in the equation of motion. So the transpulmonary pressure, as I've said it before, it's a true descending pressure. And if we measure the pleural pressure, we can get to the transpulmonary pressure, and we can do that with the esophageal balloon. And usually the respiratory therapists help us with placement. I remember we were doing it during the COVID times, like a year ago, but now we don't. I think the respiratory therapists who place it, I don't think they are around here right now. So that's why we don't do it. Otherwise, it's very useful. I remember using a PEEP of like 22, 24 on a patient, and it's it doesn't look right when you see it. But when you see the esophageal balloon, the oscillations and everything, uh, that's what the patient wants. So esophageal manometry is said to be is very important in that regard, and it's placed around 35 to 45 centimeter from the nostril. Um, and the study, which was done in New England Journal of Medicine, they studied 61 patients, and the goal in this is to keep the transpulmonary pressure at the end of expiration to less than 10, and at the end of inspiration to less than 25. So the primary outcome is not mortality, it's oxygenation in this study. But in there are secondary outcomes, including compliance, mortality, and other patient outcomes. So if you see it here, just like the PEEP FiO2 table, they have esophageal pressure FiO2 table. So for whatever pressure that you get during end of expiration on your esophageal transpulmonary pressure, they will suggest FiO2 in here. So that is the suggestion, to use this table to titrate the PEEP in these patients. So in this study, what they found out is the oxygenation is much better for patients where they used the esophageal balloon. And the other thing they found is the compliance of the patient is also, the compliance of the lung is also much better in those patients who use esophageal pressure. But if you see other outcomes like mortality, like ICU-free days, number of days of ventilation, there is no significant difference. So people are, using it here and there. And then there is the EP-Vent trial, which was done in 2014, but it was restudied in JAMA in 2019, and they restudied it in 2021 in ATS to the EP-Vent 2 trial. So in this trial, it's at 200 patients with PF ratio of less than 200, and the primary outcome is a composite score of mortality and mechanical ventilation 3 days, but the secondary outcome or like specific 28-day mortality and days free from mechanical ventilation in these patients. And what they found is for patients who use esophageal manometry guided PEEP titration and those with PEEP FiO2, they tried to compare them together, and there is no clear difference between the two curves. So they said there is no difference of using this esophageal manometry for PEEP titration. But another one, it's a post-hoc analysis in American Thoracic Society in 2021. They basically took out some things from these patients. If patients have what if they have low Apache score, no significant other multi-organ dysfunction, or if we keep the transpulmonary pressure very close to zero, between -2 to 2. When they study that, they found out that it's associated with better survival and lower ventilator and shock-free days in these patients. So the suggestion in here also from the EP-Vent trial and the other trials which were done, it can be useful when you use it for some patients, but indiscriminate use of esophageal pressure monitoring in all ARDS patients might not be a good idea. So you can use it, I would say, in very obese patients. You think, there is a lot of pleural pressure, a lot of other players in the whole process. You can do that, but otherwise using it indiscriminately for everybody might not be a good idea. So the last method is imaging. So they use it's called electrical impedance tomography. So these are new ventilators which show you dynamic images of the lung. They will show you lung expansion, collapse during inspiration and expiration, and they use those dynamic images to titrate PEEP. But honestly, I tried to understand how they decrease and they increase the PEEP, and I will be honest with you, I didn't understand it, so I didn't get a picture or anything about it. But that is one method to go down or up with positive and expiratory pressure. These are the references that I used. Thank you so much.
Thank you. Good job. Okay. Next.
So, do you have any questions before I start?
Yeah,
Yeah, I had a question that how high should in a patient with ARDS, is there a highest number of people that I should start using to recruit my lung? Like, how will I determine what's the best PEEP? Like if I started with a lower PEEP in the first place.
Let's say that you started patient, you came in, you are not the one who was the patient.
Mhm.
And you came in and you found that patient on PEEP of 5, and tidal volume 6 ml per kg, and he's still hypoxic. And so what's the PEEP how high you can go? Is that right? That's your question?
Right.
Any other questions, guys? So like the PEEP dilemma or the PEEP titration like has been like since 2002, like, and there's like going at the beginning in 2004, which was like the first time like the alveoli trial, and that's when they tried to compare the high PEEP with the low PEEP. And in that time, the high PEEP was like 14 to 16 centimeter water. And the low PEEP was around 8 plus minus 2. So in that time, they did not find any difference in mortality. They did not look at oxygenation. And in both of them, they were 6 ml per kg tidal volume. That's in the alveoli trial. That's in 2004. Then in 2006, 2008, actually, they came with the LOVES trial. And that's when they decided to go. One was like a low PEEP, and the other one to keep the plateau pressure around 28. What does that mean? Like when you came in and you found that patient on PEEP of 5, and his plateau is like, let's say 12 or like 20. So you're gonna increase that PEEP until you reach plateau of 28. And they tried to compare what's the difference in mortality. They did not find any difference in mortality, but they found there's a little bit of better oxygenation. However, there's some expert, they came in around 2008, 2007, they did the long recruitment maneuver. What they have done 25 of PEEP for 1 minute, 35 of PEEP for 2 minutes, and then 40 of PEEP for 2 to 4 minutes, and without looking at the plateau pressure. And then they would like go down decrementally after 4 minutes of keeping this. And that's what we call the long or prolonged lung recruitment maneuver. Okay. And they found that, yes, when they thought of doing it, it was like the physician standing on bedside, patients getting more hypoxic. So the only thing that he was like trying to up and PEEP, and people start doing it and they study it, and they found that's harmful, and there's like it increased death if you do it in this way. So no one should do the long lung recruitment. And if you work with someone like he's like 70s or 80s old right now, you find like, oh yeah, just like do the recruitment. And that was before, but then it came out like it's not good. So what they did, they came to the LOVES trial, alveoli trial, and there's the EXPRESS trial. They did a meta-analysis. And they, in that time, they studied if like there is mortality difference and oxygenation. They found the high PEEP table, the high PEEP, that the one that in the bottom, so has high, like better oxygenation. There's trend toward maybe better mortality, but it was not statistically significant. And they did subgroup analysis. They found these are better in moderate to severe ARDS. So if patient has mild ARDS, there's no difference. Even in oxygenation, there's no difference. But then when you look at the moderate severe ARDS, they found there's better oxygenation. However, we didn't know better oxygenation that will improve in mortality, but we will take better oxygenation. We don't want this patient to be bad oxygenation, is that right? And there's one study that compared that it's oxygenation less like 88 to 92 compared to 92 to 94, and they found that 92 to 94 they have better outcomes. Is that right? So that's better to have better oxygenation if we can without harming the patient. The question was like, okay, but how can we titrate? It's just like go with a high PEEP. So as Dr. Jasmine said, they try to standardize so you don't have to be like, it depends on each patient. So they recommend to go with the higher PEEP table, which is like this. What do you mean by higher PEEP table? When you came into that patient and you found PEEP of 5 and he's an FI2 of 100, I will take my, like when I was fellow, we have it in our like badge. So we'll look at the table and, oh, like you mean 100, the PEEP should be 24. So I'll try to start go up in the PEEP slowly until I reach 24. If there's no other limitation,
like driving pressure or blood
that's
pressure.
like the plateau pressure and the peak pressure and everything. If there's limitation, I cannot do it. Is that right? But that's what my target. That is, you would like to standardize your treatment, which I hate standardization in these type of people because you need to think, how is the lung work? What's the lung mechanic in this patient and all of that stuff. So that's why me personally, I take all of these, what he had mentioned, and try to put it in one patient. So don't just take one parameter. So if like that patient, you came in and he found PEEP of 5 and FI2 of 100%, and the patient still like let's say the patient oxygen saturation is 92. So if like someone, oh yeah, it's 92, why I need to like do any changes in this patient? And you look at the X-ray, it's bilateral infiltrate. So what I do is I start with going slowly on the PEEP up. So I change the patient on a constant square shaped flow, okay, and in a constant tidal volume. Make sure that the tidal volume is 6 or less at the beginning. And I look at the most recent ABG, and then I give it like at least 2 to 3 minutes with a constant to look at the lung mechanics, look at the patient compliance, look at the plateau, because the plateau is like changeable with changing in the mechanical ventilation settings. Is that right? Mm-hmm. So you have to have a constant flow, and that will give you like the volume control, the volume that you are giving, not ABRVC or anything like or BRVC. So that's why you will like see the exact type of volume, exact compliance static. So after I reach that point, I'll go up. Let's say it was 6, I will go up to 8. I went up to 8, the plateau is exactly the same. It did not move. What does that mean? I'm recruiting, is that right? I'm not like over distending. So I go up to 10, it's the same. Like the plateau is going up maybe by 1. So my PEEP is going higher than the plateau. So that means that I'm recruiting more than like what's going on. And while I'm doing that, I'm looking at the stress index. Is it concave, it's convex, or it's flat? At the same time, and I'm looking at the plateau and my driving pressure. If my driving pressure is going down, my plateau is still like I have a space to go, and my stress index is stable, I will keep going up. Like I usually give them like 5 to 10 minutes, and I keep going up. If I reach the point that the plateau pressure is 30, and let's say PEEP of 20 right now, and peak pressure is 35 or 32 or something like that, and the patient is setting 100%. So I'll start going down in my FI2 to just like keep like what's the lowest FI2 that I need to keep oxygen saturation around 92%. Is that right? So then I give that patient time. So I watch this patient and give him time. So unfortunately, it's easy now saying that. In real practice, there's a lot of limitation. oh, I went up in the PEEP and the plateau like was sky high. You cannot do it. As Dr. Jasmine said, let's look at the tidal volume. Can I go more down? I went more down, patient like severely hypercapnic. I cannot do it. So this lung is very stiff, unfortunately. So I need to start and rescue maneuver. So, but like you should use everything to look at the patient, not just look, don't look from one angle. Like try to look from different angle to titrate your PEEP to reach the like the limit PEEP. If I reach that, then I will keep the patient like this, and then slowly I will see like if I can go down slowly. If my FI2 is 60% or 50%, I'm good with FI2s, all right? So there's no guideline how to go down in PEEP. But me, usually I do it like by birth 2 every 2 to 4 hours. And I look at the patient. Oh, the patient oxygenation is still the same. Patient mechanical ventilation setting is still the same. Compliance still the same. I'm not losing recruitment. Everything is good. I keep going until I reach the point that the patient is extubable. If you cannot do it from the beginning, oh, his driving pressure is 20. His plateau, if I go up a little bit, it goes more than 35. It's obviously the lung is very stiff. And if we cannot do anything, that's when I start, okay, you know what? Let me paralyze him and see what I can do more. I paralyze him, I cannot do anything. He's a young patient, he can be recruited with doing like a ECMO or something like that, then I will start thinking of this. If it's not, like unfortunately, I cannot do anything. If the patient prone and everything has been done and like whatever titration of your PEEP, it will not make a big difference. So when I use a esophageal balloon, which that it was not studied in this study, it was like generalized. They did not do subgroup analysis of obese patient. Because they say like, you know what? Like no one went back to that study and looked at the people who has a esophageal balloon, the average of their PEEP comparing to the average of the PEEP like they went with the plateau pressure. Like there's no like it's direct comparison between them. So what I do is if I do like oh, it's an obese patient and I'm in PEEP of 20, his plateau pressure is 35. And he's not hypoxic. He's now not I will not even do a esophageal balloon. So I will just keep watching because we know even if I increase oxygenation, that might not increase decrease mortality. Is that right? But if the patient's still hypoxic and if I go up to PEEP, the plateau pressure will go up. Now I'm asking my question, is it because of the stress from the soft tissue? That's why I'm afraid to go up and the plateau is like giving me a limitation? Or that's real, his lung is stiff. So that's why when the transpulmonary pressure and the transthoracic pressure is important. That's why like sometimes I do transesophageal balloon to like when I started in here like a year and a half now, I used only once. So that's me personally how I titrate it. I don't know, Dr. Jasmine will.
Yeah, no, I agree. I think you have to look at all parameters, even vitals and things like that, hypoxia, until you reach that threshold where you're happy with your PEEP and kind of go from there. Because technically, if you go up on the PEEP and you recruit, even vitals may improve as well, just because you improve the recruitment, decreasing peripheral vascular resistance, decreasing load on the right ventricle. Even though you're increasing PEEP, you may actually be uploading pressure on the heart itself because of the ARDS and eclecticus. So look at all of them and then kind of go from there. That's how we that. So technically, PEEP titration should be like at the bedside with quick, especially in the acute setting. We'll talk about, day one of admission, day one of intubation, kind of being in the bedside and looking at the patient all over and doing a lot of maneuvers and seeing which one works best. And obviously cloning at the very end when the patient is
How much time do you take? Like you increase PEEP and
sometimes I don't know how I usually wait a little bit, like maybe an hour or so. Sometimes when I make PEEP changes, because sometimes recruitment to me takes some time.
Take time, yeah.
Yeah, it takes some time.
Well,
They said like at least give them like 30 minutes.
Okay.
30 minutes to.
So if you admit the patient and you go up with the PEEP and you reach like happy point and now PEEP is 18, how fast do I start to decrease the PEEP? Like 24 hour?
So I keep them like 12 to 24 hours.
Mhm.
And if everything
As
is
long,
stable,
yes.
and I'm not doing any other recruitment maneuver, everything is stable, then like after that patient, like let's say I went home, the 12 hours like out overnight, patient doing fine. The next day,
Mhm.
everything is stable. I'll start going down slowly.
Okay.
Yeah.
And
then
you would
Depends on the patient too. I mean, if
Yeah.
you know those settings and then you come 24 hours later and the
I
patient.
think they have comfort. That's what I said.
FI2 is 40, yeah.
Or not 40, but let's say PO2 is 55 and patient's still sick and saturation is 88.